Welcome back to the UEG Week Congress TV. I have the pleasure to introduce you now with me, Professor Manz. Welcome, Professor Manz. Professor Manz is the actual president of the Medical University of Hanover in Germany and one of the past presidents of the UEG. Welcome.
Welcome.
So, Professor Manz, one of the biggest breakthroughs in medicine in the last years was undoubtedly the new therapy of the virus hepatitis C with the emerging sofosbuvir, and it was actually a big emotion in the Western world as well, also for the middle and low income countries. Can you tell us a little bit more about this history?
Yeah. I think it's a masterpiece of translational medicine. Everybody is asking for translational medicine. Here it was done. I remember the time when the disease was called non-A, non-B hepatitis. Significant number of patients who received blood transfusions either after traumatic surgery or after heart surgery developed hepatitis, which in the majority developed a chronic course leading to cirrhosis and cancer. So hepatitis C became discovered as the cause of non-A, non-B hepatitis in the year 1989. And then over the years to come, there was a parallel development of basic and clinical research. The milestones in basic research were the discovery of the virus, the development of antibody tests, the development of PCR technology-based RNA testing, measuring the virus and its concentration in blood, distinguishing various genotypes, being able to develop test systems in vitro like the replicon system, and then finally in parallel to develop drugs that initially were very unspecific like interferons, helped only a proportion of patients, had significant side effects, until finally a combination of small molecules that directly intervene with three significant parts of the life cycle of the virus cycle were able to cure the virus. And so hepatitis C became the first chronic viral infection curable by medical therapy.
Amazing. So how is the future of the virus of hepatitis, the A and B? How do you see the future?
Okay, first of all on hepatitis C, we still need to find the patients and treat them. So the big topics now are screening systems, finding the patients, those that have been, as we call it, warehoused in the past. They have been treated in the majority. But we know that according to prevalence studies, there are many patients still that we have not identified. The other problem is the cost. The cost in the Western world is still high. We have generic drugs in low-income countries, but nevertheless, access to treatment is a challenge. So identifying the patients and bringing patients to treatment. The second point is we still do not have a vaccine available. So for the years to come, there will not be a hepatitis C prophylactic vaccine available. And so far, no disease has been eradicated or eliminated without a prophylactic vaccine. And therefore, the WHO coined the problem by defining criteria for elimination until the year 2030. They demand that 90% of patients should be diagnosed, 80% be treated, and by this, that 65% decrease in mortality due to hepatitis C should occur.
That's interesting. That means that even if we are today theoretically able to cure the disease on a individual level, the challenges shifted actually to the higher, to the society level, and it became a public health challenge.
Absolutely. So it's now a public health challenge, a public health problem, and there is the longest traditional congress, for example, on all kinds of viral hepatitis is the Global Hepatitis Summit or the Triennial International Symposium of Viral Hepatitis and Liver Disease. And this meeting taking place every 2 years, this really has demonstrated the shift from screening blood units, developing hepatitis A and B vaccine, identifying all the viruses with the hepatitis C at the last, now to at least half of the meeting tackling public health issues, how to bring vaccines and therapies to those hepatitis patients A to E.
Yeah, it sounds like a little bit the role of the WHO nowadays to establish a vision and a strategy to eradicate the virus of hepatitis C.
Here we, as liver people, have a problem. You know, every day more people die of hepatitis A, B, C, D, and E and its consequences than the whole year of HIV and AIDS. And imagine the publicity that HIV/AIDS achieves.
Yeah.
And liver is stigmatized. Many people think that liver patients, they are IV drug abusers, they are alcoholics, which is not the case. The majority suffers from viral hepatitis, which are infectious agents.
Okay. Yeah. Today, you led a session about the management of alcohol and drug-related liver problems. How do you see the trends actually nowadays, let's say in Germany or in Europe?
Yeah, you really pinpoint a very big problem. Overall, worldwide, 50% of liver cirrhosis is due to alcoholic liver disease. And at least 10% of all liver cancers are due to alcohol, presumably more. And the specific issue on liver cancer is that the majority of patients, 80–90%, develop liver cancer once they have developed cirrhosis. So patients first develop liver cirrhosis and then develop cancer. And here, alcohol in the Western world is the #1 cause, and very often it's a joint etiology of hepatitis B, D, or C, and alcoholism. And in particular, the north of Europe, it's alcohol which is the problem, and we still see an increase in end-stage liver disease due to alcohol.
Do you think there is a screening strategy for breast cancer? We should also establish a screening method, like for example ultrasound of the liver for people who are bigger consumers of alcohol. What do you think?
Yes, absolutely. There are recommendations, there are guidelines that every patient with liver cirrhosis should receive an ultrasound every 6 months. We know that the risk of developing liver cancer depends on the etiology of cirrhosis.
Okay.
So alcohol, iron storage disease like hemochromatosis, viral hepatitis are associated with a high risk. And also it's important that many patients with cirrhosis develop diabetes. And patients with diabetes and cirrhosis double their risk to develop liver cancer. So screening systems are very important. A particular aspect is how do we follow patients who were cured from hepatitis C and still have advanced fibrosis and cirrhosis. We know that curing hepatitis C can lead to improvement of liver fibrosis, including improvement of cirrhosis and moving cirrhosis F4, as we call it, to F3 or F2. However, we need to follow the patients even after cure of hepatitis C. The risk associated with the virus is decreased, but the risk having advanced fibrosis of liver remains. And one of the pity is that we many times in our clinics see patients with incurable advanced stages of liver cirrhosis that have been treated successfully for viral hepatitis B or C years ago.
Okay, yeah, interesting. So the new challenge is what comes after the hepatitis C.
In particular, if people have known that they have hepatitis C associated cirrhosis, that they have been cured, if they don't go to surveillance, screening, ultrasound, they play with their life.
Okay, great. A final question, Professor Manz. What are your expectations of this UEG Week of this year?
I think as a former president of UEG, I love to see UEG Week further prospering, and I think UEG as an umbrella society for digestive health, for all diseases and disciplines caring about diseases and health of the digestive system is very challenging. It's multidisciplinary. We have surgery, we have hepatology, we have the growing field of inflammatory bowel disease with a lot of new innovative biological therapies. We have pancreatic diseases, we have GI cancer. The most prevalent solid cancers are cancers of the GI tract, the liver and the pancreas. And here we see huge advances. On the other side, we still face the problem that we see significant progress in diseases like chronic cancer, but very limited in pancreatic cancer.
Professor Manz, thank you very much.